A topic that is close to my heart, neo-adjuvant therapy for esophageal cancers, was a highly debated and controversial area at the time of publication of my previous video. All the trials in the past which evaluated this area had a mixed population of both squamous and adenocarcinomas. It was later understood that these two cancers behave very differently, have very different natural courses, and are to be treated differently. Well conducted histology specific trials in the past 3 years have shed some light on this area. For example, for adenocarcinoma, Neo-Aegis and Top Gear proved that there was no additional benefit of adding chemoradiation over and above chemo alone, whereas ESOPEC, which compared FLOT with CROSS head to head, clearly proved the oncological superiority of FLOT, establishing perioperative FLOT as the standard of care for adenocarcinomas of esophagus and GE junction. When we analyze the recurrence patterns in ESOPEC, it reinforces the concepts that we learned in the cross trial. The main reason neoadjuvant chemoradiation improved survival in the cross trial was believed to be the sterilization of lymph nodes in the upper mediastinum, which are not routinely cleared by all surgeons during a standard esophagectomy. A standard esophagectomy is defined as a complete subcarinal lymphadenectomy without upper mediastinal lymphadenectomy because of the inherent risks of RLN palsy associated with upper mediastinal lymphadenectomy. In the arm which received the cross protocol, isolated locoregional recurrences were lower, understandably because this arm received two locoregional therapies, radiation and surgery. But the chemotherapy that was given along with cross, as we saw in our previous video, was a purely radiosensitizing dose, not effective systemic therapy. Hence, isolated distant recurrences were much higher. For an adenocarcinoma occurring usually in the lower one third and GE junction, the surgeon in a standard esophagectomy with a standard lymphadenectomy can achieve a reasonably good locoregional control. The main problem now is systemic failure. Hence, for adenocarcinoma, FLOT clearly became the better option or the superior option. The same is not true for squamous cell cancers, though there is a phase 3 randomized control trial from Japan which compared the three arms doublet chemo, triplet chemo, and doublet chemo with radiation and showed that the triplet chemo offered the highest overall survival. This trial has to be understood with all its implications and has to be taken with a pinch of salt. First point, this trial is out of Japan. This is the kind of surgeons that we are dealing with when we are interpreting a Japanese trial. Below the carina, all esophageal surgeons are going to do lymphadenectomy. What happens above carina, where squamous cell cancers have a very high propensity of nodal mets in the upper mediastinum and the mid thorax, is the question. The aortopulmonary window, the left recurrent laryngeal nerve looping around the arch of aorta. This is the left pleura, seen higher above. The left entire course of the left RLN, the subclavian artery, the left pleura. The entire upper mediastinum is bare. This is the right RLN. These clips are from India. Professor Dr. Navina Kumar's dissection of the upper mediastinum. And I would highly recommend you all to watch this for understanding the difference in lymphadenectomy in upper mediastinum. So, if at the end of our surgery, the field is going to look like this, the surgeon takes the onus of locoregional control. In that case, yes, we can take care of the systemic control by an intensive systemic therapy and do an aggressive surgery for locoregional control. But It is well known that this extended en bloc esophagectomy is not routinely practiced by everyone. It has a very steep learning curve, and the implications of the complications, that is the RL and palsy, in a post esophagectomy patient is very high, that most surgeons do not routinely perform it. What is usually performed is a standard esophagectomy in which only the nodes below the carina are completely cleared. Above the carina is cleared on an SOS basis. So, for a squamous cell cancer of mid thoracic esophagus, giving the triplet chemo followed by a standard esophagectomy is something similar like doing for a T4N2 midrectal cancer, giving an intensive systemic therapy with Folfox followed by an LAR, omitting radiation. So, for squamous cell cancer of esophagus, the two broad philosophies are: given intensive systemic therapy to take systemic control, followed by an aggressive surgery in en bloc esophagectomy to achieve locoregional control. This is the best that can happen to the patient because both the systemic therapy and the locoregional control are aggressive. But what is commonly done, if the post op field is not going to look like this, if the surgeon is going to perform a standard esophagectomy, the locoregional control will definitely be better with the neoadjuvant chemoradiation, which will cause sterilization of the nodes in this upper mediastinum. Hence, for squamous cell cancer, these two are appropriate neoadjuvant therapies. And for adenocarcinomas, the first question that we all ask is the patient fit for FLOT? Because many patients are not fit for FLOT, which is an intensive systemic therapy. If the patient is fit for FLOT, the best standard of care right now is perioperative FLOT based on the ASOPEC trial. If unfit, the next question to be asked is if there are significant abdominal lymph nodes. Because if there are abdominal lymph nodes, neoadjuvant radiation cannot target those lymph nodes because of fear of future anastomotic leakage. So, if there are no abdominal lymph nodes, the next best option is the cross protocol based on the cross trial. If the patient is unfit for FLOT and if there are significant abdominal lymph nodes, the only thing that we can go with is a doublet chemotherapy based on the